Welcome to GatewayC Live, Greater Manchester. Fast facts, supporting earlier and faster cancer diagnosis. Iron deficiency anemia. Think A to G. Our specialist is Dr. Roger Pruden, consultant gastroenterologist. A. Anemia.
The critical thing, though, is whether iron deficiency anemia is new and can be indicative of underlying disease, which we'll cover in more detail. So essentially, in order to have iron deficiency anemia, you've got to be anemic, have a hemoglobin less than 130 if you're male, less than 118 if you're female. It varies a little bit from lab to lab, but also have evidence of iron deficiency with perhaps a low ferritin or other labs that can indicate iron deficiency. So I think the critical thing is when a patient develops iron deficiency anemia for the first time, that could be indicative of GI blood loss over a period of time, which could cause that iron deficiency. And of course, that could be indicative of serious underlying pathology. Whereas if somebody has recurrent iron deficiency anemia in the long term without any GI symptoms, it is reasonable just to continue to treat them with iron.
B. Blood tests.
If you think somebody's iron deficient, and it's frustrating to see a normal MCV, you can look at the RDW, and if that's elevated, that should prompt other studies. So the next thing to do is a ferritin. If the ferritin is low, you are iron deficient. If the ferritin is normal, however, or elevated, you may still be iron deficient because ferritin is not completely reliable as it's an acute phase protein. It goes up with inflammation and infection, as many of you will know. And that is then the indication for thinking about doing further iron studies, and that's where you can do an iron and transferrin study. And what is confusing there is you can have a low iron on that and not be iron deficient. The thing to look at is the transferrin saturation. If the transferrin saturation is below, I think it's 15%, but the normal range comes on the blood. Will come with your results from your lab. If that is low, then you've got iron deficiency. If you've got a low iron and a normal transferrin saturation, you have not got iron deficiency.
C. Consider cancer.
So the cancers that we are most worried about are going to be those in the upper GI tract or the lower GI tract. So esophagogastric cancer, in particular in the upper GI tract, and colorectal cancer in the lower GI tract. So there is an association which isn't, I think, completely understood, explained or quantified between iron deficiency anemia and renal cell carcinoma. And renal cell carcinoma can present with a normochromic normocytic anemia or an iron deficient anemia. It is a worry that if you just do gastroscopy and colonoscopy, you might miss an opportunity to diagnose another cancer. That perhaps could be mitigated by doing an ultrasound. I wouldn't advocate doing a CT scan of thorax, abdomen and pelvis in everybody with iron deficiency anemia, because I don't think that's justified. But I think if there is another symptom that is causing concern, then it is reasonable to refer in, for example, to the RDC. We have had a couple of lung cancers that we found, and we don't know whether that is just a kind of temporal association, whether it's a causal association, whether lung cancer definitely causes iron deficiency, but we have seen that in one or two patients as well.
D. Don't forget urinalysis.
So if you've got hematuria, then again, it may increase your suspicion that there could be renal cell cancer.
E. Endoscopy.
And really focus on, is it upper GI cancer? Could it be a lower GI cancer? And what that means is that our usual paradigm in terms of investigating a patient who develops iron deficiency for the first time is to arrange urgent upper and lower GI endoscopy. And in that situation, I think an urgent gastroscopy is the next thing to do. And I would always do an urgent gastroscopy first. The reason being it's quick, it's simple, there's no prep involved, it takes about 5 minutes, and we can usually do an urgent gastroscopy well within 2 weeks. If the gastroscopy is negative, then it's reasonable to do a colonoscopy.
F. Fit.
And so the next thing to think about is if you do diagnose somebody with iron deficiency anemia for the first time, it's incredibly useful to do a FIT. Because of course if the FIT is positive, we're very much thinking that this patient may have colorectal cancer. If their FIT is negative, they're much less likely to have colorectal cancer. In a patient with symptoms, act on the symptoms. Don't be falsely reassured by negative screening fit. So just to reiterate that the positivity threshold in screening is set at 120 micrograms of hemoglobin per gram of stool. The threshold in symptomatic patients is set at 10. And the threshold for screening was chosen so that we would get the same number of colonoscopies coming through as we got with the old FOB test. It's entirely arbitrary. It's about maintaining the business and being able to maintain the offer to screening patients so we can do them in a timely way. It might come down over time, but it is entirely possible to have colon cancer and have had a recent negative screening fit.
G. Greater Manchester Referral Pro Forma.
Most important thing we want to establish is whether or not they've got cancer, and if it's going to be caused by cancer, then it's going to be an upper GI cancer or a lower GI cancer. And we want to diagnose upper GI cancers as quickly as we possibly can. So we do an urgent gastroscopy. As I said before, it really isn't too difficult to do. It takes 5 minutes. And then a colonoscopy is slightly more detailed, of course.
Think A to G. A. Anaemia. B. Blood tests. C. Consider cancer. D. Don't forget urinalysis. E. Endoscopy. F. Fit. G. Greater Manchester Referral Pro Forma. GatewayC Live, Greater Manchester. Fast facts, supporting earlier and faster cancer diagnosis.